Okay, good afternoon, everyone, and thank you very much for joining us for another Aorta Chat interview as part of our aortic disease awareness campaign with the TSMA and Aortic Hope. Today, we are honored to welcome Dr. Pedro Catarino with us. He's the Director of Aortic Surgery here at Cedars-Sinai. How are you doing today, Doctor?
Very good, thanks, Adam. Thank you for asking me to do this interview.
And thank you very much for making the time for us. So if we could start off with a little bit of information about what inspired you to become a cardiac surgeon and I guess then subspecialize within aortic surgery.
I guess it's a long journey. First of all, I wanted to be a doctor, and then I thought, well, I want to be a surgeon. I think what really got me with the cardiac surgery is the atmosphere in the OR, and the fact that on the one hand you're doing surgery, which is a very anatomical issue that you're dealing with as a doctor. At the same time, you're dealing with the patient's physiology and managing how they are able to survive while you're doing the operation on their heart. And of course, I had role models or mentors that I looked up to and admired. And what I really admired about the cardiac surgeons that I worked for was that they always seemed to know what to do, even in the most critically important moments. And so I aspired to be like them, and that's why I chose this career.
And we just had a wonderful didactic last Wednesday, I believe, where you told us you had a slide with a lot of turkeys on for our student viewers. Could you tell us a little bit about what turkeys have to do with
Oh,
the aorta?
yeah. Okay, well, it's quite an old story. So in the northeast of the United States, there's some very big turkey farms with really thousands of turkeys. And the farmers who ran these farms were noticing that every now and then, many hundreds, even thousands of turkeys would die all of a sudden. So the vets did autopsies on these turkeys and found that they had had aortic dissection. So actually, turkeys are susceptible to aortic dissection. And they managed to figure out why these turkeys were having aortic dissection. It was because the farms were located near an airport. And when the airplanes came into land, that very much stressed the turkeys, caused the blood pressure to go up, and then they suffered these dissections. And so the way they dealt with this problem was to put blood pressure lowering medication into the feed that the turkeys were given. This is before many of the blood pressure medications that we have today. That the drug they used was something called reserpine, a very old antihypertensive. And by putting this in the turkey feed, they were able to lower the turkey's blood pressure and avoid these turkeys dying of dissection. And that observation leads to one of the first treatments that we have for aortic dissection. So when the patient comes into hospital having suffered the dissection, the first thing we want to do is lower the blood pressure, and we lower it in a particular way that also reduces the force of contraction of the heart. For the medical students out there, that's the DPDT, the rate of rise of pressure in the left ventricle. And so we use drugs to do that, to blunt the chance that this forceful contraction will result in a rupture, which could result in the patient's death. So that's one of the first principles of management of aortic dissection.
So, speaking of the principles of managing aortic dissection, I know the old philosophy used to always be stabilize the patient, get them off the table, sometimes entailing a hemorrhage, and then coming in later to do more extensive repair.
Okay, yes.
Would you say that philosophy still stands true today, or has it evolved?
Yes, I think it's in evolution. I wouldn't say that it has completely changed. Type A aortic dissection is a surgical emergency. Patients are immediately transferred to the OR, and they need to undergo a repair. And of course, the principle is to save the patients, prevent them from dying. And that patients die because of two issues with aortic dissection. One is bleeding. So bleeding usually would come from a rupture. So it could be that the ascending aorta ruptures, or actually that you bleed around the ascending aorta into the pericardium, the sac around the heart, and then that stops the heart from expanding, and so that could be fatal. But I group that all under bleeding. And then the other reason patients die is they have malperfusion. So that means the branches of the aorta may become blocked, and they could be the branches to the heart itself, so it can mimic like having a heart attack. It could be the branches to the brain, cause a stroke, or any of the other branches to all the organs which the aorta supplies. So that's the principle. We need to stop the patient dying from those two things, and mostly that is dealt with if you just replace the ascending aorta, so 2 or 3 inches of damaged aorta. This is the part of the aorta that's most susceptible to rupturing, and also if you repair that part, you'll stop any blood going into the pericardium, causing tamponade, and you should be able to direct the blood into the true channel, what we call the true lumen, and that would correct any malperfusion. Unfortunately, it doesn't always work that way, and even though I think surgery has advanced, the ICU has advanced very much in the last 2 or 3 decades, the overall rates of operative mortality following type A dissection repair are pretty stuck at about 1 in 5. So 1 in 5 patients who get to have an operation don't survive. And I think that the room for improvement is in doing a more extensive initial repair. So not just replacing that 2 or 3 inches of ascending aorta, but actually going into the arch and putting perhaps a stent in the arch that will properly expand the true channel, the true lumen, and obliterate the false channel or false lumen, and also support the sutures that we put in to do the repair. And I think we don't have strong scientific evidence to support that as a strategy for everybody. But my feeling is that we're going to be progressing towards doing more patients that way than we do at the moment. And hopefully we'll get that operative mortality down from the 20%. I should say that the patients who have a type A dissection who get to the operating room are the lucky ones, because half of patients having a dissection die at the time. They don't reach hospital. And half of those who reach hospital die before they get to the operating room. So actually, there's a lot of scope for improvement in the pre-operating room phase of the type A dissection.
And when you talk about the pre-operating room phase of the dissection management, we're trying to spread awareness this month about thinking of that initial aortic diagnosis when someone walks in. I mean, what's something you wish more people knew about aortic disease?
Yes, I think, so I think that patients who don't know that they have aortic disease themselves, of course, what I'd like them to know is if they have a family history of aortic aneurysm or dissection, that they're at increased risk, so that if they do present with the typical symptoms of chest pain or collapse, that they communicate this family history, so that the doctors who initially see them think about the aorta. And then, of course, I want the doctors who are seeing these patients to think about the aorta when they see a patient with chest pain. Out of 100 patients who have cardiac chest pain, 99 will have a myocardial infarction, but 1 will be a dissection. So it behooves the doctor to be really thinking about, could this be an aortic condition? And then sending them for the appropriate test. Really, the key test is a CT scan, which is really widely available in emergency departments around the country.
When you follow patients in your aortic clinic, and for those elective cases that you're planning ahead, if they have, what are some of the fears they have when they're told they need aortic surgery, and how do you help guide them through that?
Yes. Well, so it's rarely black and white whether they need aortic surgery or not. It's usually a balance of risks and benefits. So mostly the risk is determined by the size of the aorta. So they've usually been referred to the clinic because their aorta is slightly dilated. And if it's very dilated, obviously the risk of it rupturing is very high. and that outweighs the risk of the operation. But at smaller diameters, it may be that the risk of it rupturing is not so enormous. Maybe it's 2 or 3% per year, let's say. And the risk of intervention, so typical risk of intervention for this sort of surgery is about 1%. So, we have to weigh up whether the 1% risk of the operative intervention is worth the 2 or 3% per year. And so that may be very much influenced by the patient's age. So, if the patient's in their 80s, it may be very acceptable to take 2 or 3% per year. Over a 10-year period, even though that risk applies each year, it still doesn't reach halfway. You're still less than 1 in 3 chance that you would have a problem with your aorta. So that might be reasonable for that patient. Whereas a 50-year-old patient, it's completely different. They don't want to be suffering that 2 or 3% per year. So the discussions that we have in the clinic are very much about that. And many people have heard about stenting of the aorta, and so they come with the hope that their issue may be treated by a stent. But actually, most of the prophylactic surgery that we do for patients who have dilated aortas are very safe, and but they're open surgeries. So because they're so safe, stenting has to evolve quite a lot to reach the level to replicate what we're able to do with open surgery. So mostly stenting is not an option for these sort of patients. So they have to come to terms with the fact of having an open procedure. Sometimes that could be minimally invasively, so it wouldn't necessarily have to be a full incision through the breastbone. It could be a partial incision, but not in all cases. In some cases, it needs the full incision and the full heart-lung machine. And really, that is, for a patient, that's a very big thing. It's a week in hospital. It's really 6 weeks recovery time. So those are the sort of things that we discuss in the clinic.
Of course. And a lot of our viewers today are aspiring cardiovascular and vascular surgeons. You mentioned some of these new minimally invasive endovascular technologies and techniques coming in a field that seems like it's always evolving. How would you recommend the young trainee kind of balance these newer interventions with more conventional time-tested principles of aortic surgery?
Yes, I think obviously the future is very much about doing less invasive procedures for patients, and that may be that it's done through the vascular pathway, so endovascular techniques, so stenting, and there are great advances in the stent world with branches and stents which are able to cover the arch and even go into the ascending aorta. And then there are also minimally invasive options of surgery, and for example, making keyhole incisions and using a robot to do the repair process. I think that getting into this field, young people need to be aware of how we've got to the point where we are today, which is with quite a lot of open surgery and correcting the anatomy that is wrong in the patient. So we do anatomical repairs. That's the fundamental principle. But I think they should be looking to the future and looking to these minimally invasive options, which are very likely to advance with technology and engineering. And even if the stenting and the minimally invasive, say, robotic surgery takes over, I think there will still be places for the open surgery, and also the need to manage the circulation in a very sophisticated way. So using the heart-lung machine to allow us to stop blood flow in certain areas of the vascular system to allow us to do those minimally invasive procedures. So I think there'll always be a need for young people to know how, the open principles and to know how heart-lung machine works.
Well, it's certainly an exciting time for all of our
I think it's a very exciting time. I mean, I think technology is our friend and is helping us treat more patients and treat them better. And I hope your viewers really embrace that. And we're looking to them to think of the next procedures of the future. And you, of course.
Hopefully. Well, thank you very much for taking the time to speak with us today. I do want to be respectful of your time. I know you have a trip coming up, but do you have any closing remarks for our student listeners, patient listeners, anyone who tunes in to this show?
I mean, I think, work hard and follow your passion. And, if you reach blockades or hurdles, there are lots of resources to help you get past the blockades, get over the hurdles, and reach out to the various resources that are available. And congratulations on doing this. Is it a podcast or
sort of? It's a Twitter weekly Twitter space interview. I guess
so congratulations for doing it, and I hope that we're able to reach many people and increase the awareness of the aorta. Thank you for your work.
Thank you for the work you do, and thank you to all of our viewers who tuned in.
Thank you. Bye bye.